Hi, everybody. My name is Shahryar Banouri. I'm an assistant professor at the University of Anglia in Norwich, in the UK. And I'm here to talk to you about encouraging service delivery to the poor. This is a paper that's joint work with colleagues at the World Bank and the Inter-American Development Bank. And it's actually an interesting paper. It's a little bit unusual, so I'm going to give you a little bit of background to start with. Now, for those of you that might not know, Burkina Faso is a landlocked country in West Africa. It's among the poorest in the world. Things are improving, but for the longest time, it's been amongst the poorest in the world. And one of the concerns that Burkina Faso has routinely had is its huge proportion of people that live under the poverty line. So it's a massive number of poor people. Estimates vary, but some say nearly 80% of the population is engaged in some sort of subsistence farming. 40% of the population live on less than the international poverty line, $1.90 a day. And so there's huge issues of poverty and inequality in Burkina Faso. Now, one of the concerns that the government has had is in trying to improve its service delivery, specifically healthcare delivery, for the poor. So the health sector in 2011 started implementing what we call performance-based financing programs. Now, performance-based financing programs are basically straightforward. They're incentive schemes for service delivery units to be able to get financing on the back of performance. So the idea is that there's a series of quality-based output indicators that we all agree are the ones that we'd like these service delivery units to deliver. And then at the end of a pre-specified time interval, we evaluate these service delivery units, and the ones that made the threshold, made it to the benchmark, get additional financing. So it's a way to incentivize service delivery units to improve their performance. Now, while in theory that sounds well and good, implementation-wise, it can be quite challenging. So along with the World Bank, the government of Burkina Faso implemented randomized control trials, or RCTs, to evaluate the impact of such schemes. Now, where we come in is we're not running the randomized control trial, but we were asked to contribute to the mechanisms that underlie the randomized control trial. So typically randomized control trials are high-level field experiments. They can uncover lots of things, particularly impact. They're pretty good at doing that. But in terms of the mechanisms, they tend to fall a little bit short, particularly if you're trying to implement sort of incentivized measures to try and uncover mechanisms. So that's essentially where we come in. Okay, so what I'm going to present to you is a lab in the field experiment that's kind of going to look at service delivery for the poor in the context of Burkina Faso, where poverty is a major issue. Now, as I said, Burkina Faso is a landlocked country. It's in West Africa, just on the edge of the desert, and it's quite poor. It's been struggling for quite some time. Here's a little bit of facts about that. Population is nearly about 20 million as of 2018, I believe. It's amongst the poorest in the world. At the time in 2011, it was well at the bottom. Currently, it's 114th. Still not great, but not as bad as it used to be. 40% of the population lives below the poverty line. That's still true today. Life expectancy is about 60 years as measured in 2016. Health outcomes are particularly problematic. Maternal mortality is about 371 out of 100,000 as measured in 2015. And then lots of health issues, particularly contributing factors to child mortality. You have things like malaria, acute respiratory infections, diarrhea, malnutrition, and those account for bulk of child mortality. At the same time, per capita health expenditure was about 6.4% of GDP. So also, I mean, it's not a lot, but it still indicates, Burkina Faso's sort of emphasis towards health. Now, as I mentioned to you, the poor population in Burkina Faso is particularly massive. So what they're trying to do is improve health outcomes for the poor. And the key question that we're going to be dealing with in this paper is whether financial incentives can help in improving service delivery for the poor. Now, that relies on a couple of assumptions. So the first one is whether service delivery to the poor is really lower. And the answer is yes, it is. I'm going to show you a little bit to that effect. But in fact, health outcomes among the poor are systematically lower everywhere in the world, even in developing countries, and even in countries like where I am in the UK, where healthcare is free at the point of use. Now, the second question is, why wouldn't financial incentives help? So if you're an economist, the first thing you think about is financial incentives. But there's a large literature on motivated agents that I'm just going to touch upon that says that, yes, money matters, and it's a pretty good motivator, but it's not everything, and we should look at ways to in which money impacts people and effort. Now here's a few graphs. Sorry about this. This is a little bit busy, but I'm just going to quickly touch on these. Basically, the idea here is health outcomes are worse for lower income families pretty much everywhere. So the top two graphs, the one on the top left, this is data from the US, and this is the self-reported health outcome by income class of 2011 in the US. So if you're earning less than 25,000, so you're classified as poor, about 22.8% self-report that they're currently in fair or poor health. And what you see is that proportion starts to drop off with additional income classes. So in a place like the US, developed country, you have this systematic effect on health outcomes by income class. Another way of looking at this is this data on the top right. This is also fairly old, and it's also data from the US. But the idea here is that this is basically life expectancy after the age of 25 for different groups, again, by income class. So for the poorest income class, you can expect to live about an additional 49.2 years after the age of 25. But for the highest income class in the sample, it's 55.7. So that's another almost 6 years of additional life expectancy by income class. Now, Burkina Faso is no different. So the bottom two graphs are health outcomes in Burkina Faso. And again, on the bottom left, you've got child mortality. You see the highest levels of child mortality for the lowest income quintile, the lowest and the second lowest. As I mentioned to you, both of these income quintiles are basically living under the poverty line. But then for the highest income quintile, it's a lot lower, nearly half. Similarly, you've got percentage of deliveries at health facilities. So what you see is the highest income class is almost all of them are having deliveries at health facilities, whereas for the lowest income quintile, it's about half. Right? So stark differences in health outcomes, but also health access. Okay, now on this graph actually shows life expectancy at birth across countries, right? And what you see is on the y-axis, you've got life expectancy at birth for the entire population. On the x-axis, you've got per capita income. And basically, you see this consistent, well-documented positive relationship. So countries that have higher levels of per capita income see higher life expectancies at birth. There's lots of heterogeneity, of course, but you see a significant shift. And the answer is, the question is, why is that the case? The literature on health says, well, there's lots of reasons that go into it. There's affordability, there's worse environment and housing, worse transport, low education, there's other psychosocial factors. What we're going to actually talk about in this paper is actually bias of healthcare professionals. Okay, so I'm going to come to that. That's an additional reason that goes beyond these issues of access. That's not to say that access is not important. Access is still very, very important. This is looking a little bit deeper into that equation. Okay, now the literature is kind of consistent, and I'm not going to cover all these papers here, but here's references for you if you're interested. Basically documenting all over the world health outcomes that are worse for the poor, and that improving health and education for the poor specifically requires greater resources. Okay. At the same time, we also have a separate literature which is about pro-social motives. Okay, so now, as we all know, in public sector, particularly in health and education, you have what we call incomplete contracts, which means that you can't implement a private sector style contract about, how many students did you teach, or average grades, and condition salaries on that. Right? There's lots of issues, including issues of scale and equity and so on. But what we're going to be talking about here is that even though you have incomplete contracts in the public sector, you still have other sources of motivation that's separate from money that allows you to keep effort high even when contracts are incomplete. So there's a large literature about precisely this, on things like pro-social motivation, which is people join the public sector because they want to serve the public, and even when the contracts are incomplete or have no real effort-based component, yet effort still remains high. So I list a few papers here. But we're also concerned about this because financial incentives are useful in improving effort, but also can lead to things like crowding out or diminishing returns, so as to yield inefficiencies in the system. Okay, so what I'm really proud of, and I encourage you to check it out, is one of my favorite shows, Last Week Tonight with John Oliver. Actually, it talked about this issue of bias in medicine. And one of the reasons why this has sort of come to be is that there is now this understanding that people might be systematically treated differently because of who they are, where they're from, some sort of characteristic that leads to lower levels of service delivery for systematically for some groups over others. It's an important issue, and we're going to look at it more in depth today. But one of the reasons why you might not have thought about it is because we don't necessarily think of doctors as how can I put it, as human beings, if you like, right? So we expect medical professionals to be healing the sick and have no real biases or preconceived notions about the patients that they see. But of course, healthcare professionals are human beings, and just like the rest of us, they carry biases in their heads, which can lead to issues of discrimination. Okay. So one of the things that I want to impress upon you as we were conducting this study is that is this issue of whether or not serving the poor is different from serving the non-poor. Now, this you might not have thought about. We actually spent a lot of time thinking about this issue, interviewing medical professionals in Burkina Faso and in other places, asking whether or not poor people are systematically different from non-poor in terms of the resources that they require. Okay, and what this is basically data, but also literature that points to complexity in poor cases. Okay, so one of the dimensions in which the poor are different from the non-poor is the level of complexity in their system. So healthcare professionals, they sort of agree, and that's what this graph is showing, that when serving the poor, how important is it that poor can have more complex health problems than non-poor patients? We asked us a sample of students, but also healthcare professionals, healthcare students and healthcare professionals, the question, and most, as you can see, most of the sample agrees that this is an important factor. The idea is that poor patients tend to have more symptoms, which makes diagnosis harder. So it takes longer to try and diagnose them, particularly because you have more symptoms that are present. The second aspect that makes poor really different from serving the non-poor is communication. So it's this is both healthcare professionals and students agree, students less so, more so healthcare professionals, that communication with the poor tends to be more difficult. So it's more difficult to get them to explain their symptoms or discuss their problems. More difficult to understand. And then finally, and this is kind of related to both of those earlier things, so poor patients tend to have present with more complex problems, and also it's more difficult to communicate with them, and so that leads to a greater amount of time that's required to resolve poor cases. And again, this is data from healthcare students and healthcare professionals. Vast majority agree that it takes considerably longer. Okay, so with that, and that's basically all the setup. And I understand I've spent a long time on the setup, and finally I come to the experimental design. The good news is the results are fairly straightforward and very quick, but I'm going to spend time on the experimental design trying to explain to you how we sort of set this up. But this is a rather complex experiment, so I need to take a little bit of extra time talking through all the design details. Now, what we're doing is, again, as I mentioned to you, the government of Burkina Faso is interested in implementing a performance-based financing scheme. So they want to provide additional financial incentives for health professionals on serving the poor. What they want to do is give health professionals more money the more poor people that they see. And so they implemented a scheme sort of like that, where they were trying to overcompensate health professionals for serving poor people. Now, effectively, how this works in implementation terms is that poor people got something like what you would understand as a healthcare card, basically a little card that says your fees are going to be paid by the government. So you go to a health clinic, you show them the card, you don't have to pay any fees upfront. Okay. Now, what the clinic does is it takes all these cases and then bills the central government. Okay. And so that's what they do. Now, in some places, what the government of Burkina Faso did was they gave them exactly the same amount of money. So basically compensated clinics for seeing the poor. In other places, they implemented what they called a poor bonus. So this was additional funds that were given to serving poor poor patients. Now, what we're going to do is simulate that policy in a lab setting and study behavior of health professionals. Okay, so what we're going to use for this is a sample of real health professionals. These are doctors, nurses, and midwives working in small health clinics in rural Burkina Faso. We're going to assign them to 4 different treatments, and I'm going to explain how that works in a little bit. Our baseline treatment is going to be this thing called flat pay. So this is an unconditional salary. And then we have 3 additional treatments where we provide bonuses to healthcare professionals according to the type of patients that they see. So I'll explain those in detail shortly. Now, what we're going to measure, there's 2 measures that are particularly important here. The first one is allocation of effort to the poor. What we need to do is observe how healthcare professionals allocate their effort towards poor patients and non-poor patients. I'm going to show you what that looks like. And then the second measure is what we're calling pro-poor motivation. So this is the extent to which you are intrinsically motivated to serve the poor. Okay, so it's kind of like pro-social motivation, but targeted towards a specific group. Pro-social motivation is just about serving everybody. Pro-poor motivation is specifically serving the poor. Okay, so now let's talk about how we measure the allocation of effort towards the poor. What we need is an effort task that requires knowledge and effort in a medical context, but also that can be incentivized. Now, how we started thinking about this is, well, we started with a standard approach to measuring medical knowledge. And how this works is with survey vignettes. So you have enumerators that go up to health professionals and they say, imagine you're seeing a patient and the patient complains that he's got these things wrong with them. What do you think is their issue? And then the doctors or healthcare professionals, they rattle off a series of diagnoses, which the enumerator marks down. Later on, they cross-check and come up with sort of an accuracy rate, which gives you a measure of medical knowledge. Okay. On the other hand, so these are sort of standard paper-based vignettes. Then you have things like fake patient studies or audit studies. These are where you train actors to go in and present different problems, and then you record the interaction with the medical professional. Okay. Now, what we're going to do is we're going to do a bit of a middle approach. We're going to simulate. So it's essentially, think of it like a video game. We're going to simulate a clinic. Our subjects are going to view a video of a patient telling them what their problems are. The subjects are going to view the video, and then they're going to tell us what their diagnosis is, what a treatment is, what a follow-up schedule is, and what an alternative treatment is. This is all multiple choice. There's 5 options, one of which is the correct option, and all the information that's needed to diagnose is presented to them. If you're interested in how we do this specifically, we've got a paper out in Social Science and Medicine that explains this in greater detail. Okay. What I want you to think about is, or capture this picture in your head, right? So here you see a picture of a rural clinic in West Africa. This, by the way, is not in Burkina Faso. This is a picture of a clinic. I believe this might be in Ghana. But the idea there's like a waiting room, generally outside this little covered shed, and then somebody comes in and brings patients in to see the doctor one by one. The doctor is in the room. So essentially that's what we're going to do. Sorry, this is a bit of a busy slide, but I'm going to break this into components in just a second. But the idea is that there's a virtual clinic. So think about it, you're like a doctor. You're basically in your clinic for one day. Now, this one day in experimental terms means about 11 minutes in total. You've got 16 cases sitting outside your door, so this is your waiting room. You can select the cases in any which way manner that you wish. They're all just sitting outside, but they're grouped in, basically the cases are in 2 groups. These are in poor cases and non-poor cases. Okay, so we've got this list here, and I'll show you, I'll blow it up in just a second. But what happens is if you choose a poor case, you see an actor giving you a sort of description of what's wrong with them, and if you you treat them and diagnose them appropriately, you'll generate donation to a poor school. Okay, so effort here actually matters in terms of it generating benefits for the poor. Similarly, if you go the non-poor case route, you'll see an actress who's relaying off her symptoms, and if you get the answers correct, you'll generate benefits for a non-poor school. And then these cases are also different. So how they're different is poor cases take longer. As I told you, there's evidence to show that there is a time disincentive. They tend to have more symptoms, so there's a complexity disincentive, and they're more difficult to understand. They're a communication disincentive, and we'll talk about how we implement that in just a second. But if you treat a poor case effectively, you're going to generate benefits for a poor population, meaning donation to a poor school. Okay. Here's a case menu. This is a little bit of a blow up from the earlier slide. And here the idea is that there's 2 types of cases. Sorry, this is in French. Burkina Faso is Francophone, but two types of cases, a poor case and a non-poor case. Okay, so type X is a non-poor case, type Y is a poor case. Now, what you know right up front, and that's what this description says, is that if you select, say, poor case or type Y case, the donation is going to go to a different school, the poor school. The video is longer, so it's going to take more time to view the entire video, and the difficulty of the case is more complex. Okay, so it's a more difficult case, and that's the information that's available to the participants when they choose their cases. So they know that if they choose a poor case, it's going to be longer, it's going to be more complex, but the money is going to go to a poor school. Now let's talk about how the videos are going to be different across non-poor and poor cases. Now what we're trying to do is simulate a poor patient and a non-poor patient to the extent that we can. So this is a picture of a non-poor patient. There's our lovely actress. She is going to be relaying off a non-poor version of a case, and she talks to the doctor. She says, hello doctor, help me, and so on. I'll show you a transcript in a second. This is a poor patient, and what you can immediately observe is it's the same actress, by the way, in case that wasn't clear, but the clothes are different. She's sitting very differently, and essentially more pleading her case. And so what you can see is clear differences between the non-poor patient and the poor patient in terms of communication as well. Now here's a transcript of a poor case. The words in red are the additions to poor cases, right? So a non-poor case is the words in black. The poor case is the words in black plus the words in red. Okay, and so you can read over this if you like, but the idea is that they're explaining the issue, but there's also some additional communication problems, communication difficulties, and as well as additional symptoms. Okay, and so all of that means that the video of the case is going to be longer, and there's going to be more symptoms that you have to try and sort through. Okay. Now here's a screenshot of a sample case. You see the video is playing on the top left. On the right, there's additional statistics, vital statistics that you need to know to diagnose the case appropriately. And then at the bottom is your options. So you select the options that you think are appropriate. Here's the four possible questions. What's the most probable diagnosis? What we have is a correct response, two almost correct responses, and then two clearly incorrect responses. What's the most appropriate treatment? When you'd like a follow-up, and what's an alternative treatment, right? So each case requires you to answer these four questions. Okay, effort matters. So we also tell our subjects right up top that if they answer a poor case, the donation is going to go to the school on the right. This is a real poor school in the capital, Ouagadougou, or just on the outskirts of it. If they choose a non-poor case, the money is going to go to a non-poor school. That's the school on the left, and you can see stark differences in the screen, capture the pictures of the children. And so that's basically it. So what we're going to come up with at the end of all of this is, in 11 minutes, you can see any cases in any order that you wish, and the outcome measure is basically going to be the number of poor cases that you saw divided by the total number of cases in a particular in a particular time frame, which is 11 minutes. Okay. Now these are 16 cases in total, half poor, half non-poor. Okay. And so what we expect, what we're going to see is this variation in this proportion. So a proportion of 0 means you saw no poor cases and all non-poor cases. Proportion of 100 means you saw all poor cases and no non-poor cases, and so on along the line. And again, poor cases are different in line with real-world differences. So, just a quick summary, it's a medical real effort task that mimics a health facility. We've got a waiting room with 16 patients, 8 poor and non-poor. Correct responses generate donations to the charity, and the treatments are going to vary the incentive structure, and I'll show you that in a second. But before I go there, I want to talk about our second measure, which is pro-poor motivation. So this is our way of trying to measure how much you care about serving the poor. Okay, and essentially what we're going to use for this is a modified dictator game. You know, dictator game. I give you some money. I ask you how much you'd like to donate to either another person or a charity or something like this. What we do is we pair health professionals with the same 2 schools. We give them a fixed amount of money, and we say, okay, how much would you like to donate to poor school, non-poor school, and you can split it up however you like. And we show the pictures again. It's the same schools, same non-poor school, same poor school, and what we have is this distribution right here of pro-poor preferences. Okay, so essentially the measure is the amount that you donated to the poor school divided by the total donation. Okay, so a proportion of 0 basically means you gave no money to the poor school and all your money to the non-poor school. Proportion of 100 means you gave all your money to the poor school and no money to the non-poor school. And basically what you see is a strong mode at 50%. So there's a significant proportion of the sample that's splitting it evenly, but then beyond that, you see a lot more people giving more money to the non-poor school relative to the poor school. Okay, so that's our measure of pro-poor motivation. All right, now here's our treatments. Okay, we've got 4 treatments. Our baseline one is a salary. So for the clinic, we are going to give you 4,000 CFA, the Central African francs, for resolving cases in the clinic. Okay, this is completely unconditional. It's got nothing to do with anything. You just get your salary and that's it, right? You can see cases in however proportion you like, and so on. Okay, then you have a non-poor bonus. So the non-poor bonus includes that fixed component of 4,000 CFA. So you've got that. Plus, for every non-poor case that you see, you get an additional 100 CFA. Now, what this simulates is the real-world scenario that's going on, where the fees for using the health clinic can only be paid by non-poor people. Okay, so non-poor people are able to pay their fees, poor people can't pay their fees. Okay, so we're sort of simulating a real-world scenario before the implementation of any kind of performance-based financing or any scheme like that. Then we have another treatment called the equal bonus. So this is the first intervention. This basically was like the Medicare style intervention. The government is going to pay the fees for poor people. Non-poor people pay their own fees. So no matter which type of case you see, you still get 100 CFA per case on top of the 4,000 CFA, which is your fixed component, your salary. And then finally, you have this poor bonus scheme, which was being trialed in Burkina Faso. And the poor bonus scheme, you've got your fixed component, 100 CFA for seeing a poor, non-poor case, and then 200 CFA, so double for seeing poor cases. All right. So the whole study has about 1,000 health professionals from health facilities in 5 regions. Yes, these are real health professionals. And I'm going to skip over some of these implementation issues, but these are real people and these are real stakes. So the idea is, just to recap, we're experimenting using an experiment to test the impact of financial incentives on effort that health professionals allocate to the poor. So we're going to look at the effect of this poor bonus assigned to 4 different pay schemes: a flat pay, which is our baseline, then a non-poor bonus, an equal bonus, and a poor bonus. And we're going to measure 2 things. We're going to measure allocation of effort to the poor and pro-poor motivation. And basically, our main variable, dependent variable that we're interested in, is allocation of effort to the poor. That's what we want to increase, right? We want to get healthcare professionals to increase their allocation of effort towards the poor. Now, here's the results. I only have 5 minutes left, so it'll seem like I'm rushing through this, but bear with me. They're actually quite straightforward. First, by treatment, here's the number of cases seen across each of these treatments. The salary scheme has about an average of 5 cases that are seen. Non-poor bonus increases the number of cases. Now remember, again, there's a fixed amount of time in which to see cases. And so if you lump all your effort towards non-poor bonus, they take less time. Therefore, you're going to see an increase in the cases, and that's what we see, significant increase. Equal bonus brings the number of cases back down to baseline. And then you have the poor bonus scheme that again increases the number of cases. This, by the way, is significantly higher than the salary, but it is not significantly higher than the equal bonus. Okay, so it is nominally higher, but not significantly higher. But the key thing we're interested in is the allocation of effort towards the poor. Okay, so now this is basically this graph shows the proportion of poor cases seen, okay, across our 4 treatments. So on the left is our baseline. This is our salary, and what you see is about, on average, about 44% of cases that are seen are poor cases. When you implement a non-poor bonus, the proportion of poor cases seen is massively reduced, down to 20% or just above 20%. When you implement an equal bonus, that increases and again brings it back in line with the salary. But I want you to notice there's all still significantly lower than equity. Right, so in the clinic, we start off with an equal number of poor cases and equal number, 8 poor cases and 8 non-poor cases. And it's only under the poor bonus scheme where you come back to equity, right, where it's almost exactly on 50%. Okay, so what we can say is that the poor bonus is effective, but I will also mention that there's an asymmetry around equal bonus. Okay, so there seems to be some sort of diminishing returns when it comes to implementing a poor bonus scheme. You double the amount of incentives to the poor, that increases effort for the poor, but not as much as you might think. Now, this is a graph that shows the relationship between pro-poor motivation on the x-axis and allocation of effort to the poor on the y-axis. Okay, this is just for the salary treatment, and what you see is a clear upward slope. So the more pro-poor motivated you are, the more effort you're going to exert towards poor patients. That's fairly straightforward, nothing very controversial, just for the salary treatment. Now, if you compare this, on the left we have the salary treatment against the non-poor bonus treatment on the right, what you see is that relationship essentially disappears. Okay, this is for the non-poor bonus treatment, it's negative It's not significant, but it's negatively sloping, certainly significantly different from the salary treatment. And so what happens is those that are most pro-poor motivated, those that care the most amount about the poor, they respond to the incentive by allocating their effort away from poor people onto non-poor people. So if only non-poor people can pay their bills, even though our health professionals care about poor people, they respond to the incentive by reducing their effort towards the poor. Okay. Now here is the equal bonus treatment. Again, you see it's a flat slope. Certainly doesn't look like anything like the salary treatment, but it's only when you come to the poor bonus treatment where you have a slope that looks almost exactly like the salary treatment. Certainly these two slopes are not significantly different, which we test in this regression table, which I don't really have time to go over, but we can talk about it in the discussion later. Okay, and I'm out of time, so I'll just take a minute to wrap up. Basically, what we're trying to do in this paper is we're trying to test a real-world incentive scheme that the government of Burkina Faso implemented for serving the poor. Okay, and what we're trying to come up with is a recommendation for the government of Burkina Faso in terms of how healthcare professionals would be expected to respond under these circumstances. Okay, and so what we find is, well, I mean, a few things that we learned during this process. One thing was that there's a strong disincentive to serve the poor, and people respond to that disincentive for better or for worse. It takes more time to see them, and if your objective is to heal as many people as possible, then in fact you'll reduce your effort on poor people at the point of serving them. Yeah, of course, later on, I mean, if you take into account the fact that we all, my sickness affects other people's sicknesses and so on, it might, it's better for all of us if healthcare workers treat the poor, but in fact, in general, that wouldn't happen in a situation where poor people can't afford to pay user fees. When you implement a Medicare style system where the government pays for the healthcare bills for poor people, you still see an underserving of the poor in line with eliminating user fees altogether. Okay, and that's essentially because you don't compensate workers for the additional effort or additional resources required to treat poor patients. And so when you implement a poor bonus, you're able to replicate those incentives effectively. You're able to compensate for the disincentive for seeing poor patients, and that gets you closer towards equity. A slight addendum to this is the government of Burkina Faso has in fact implemented a poor bonus scheme across their healthcare system. Okay, now I'm completely out of time. I'd like to thank you, and I look forward to your questions and discussions and so on this or any other issues around that. Again, my name is Shahriar Benouri from the University of East Anglia. Thank you very much for listening.